Oh. Okay, should be all set.
Oh, she is.
It's all good. It's all good.
Hey, sorry about the delay.
Hi there.
Hey, I clicked on the wrong link, so I apologize to everyone who's been waiting. But I'm Erin Kim. I'm one of the hospitalists over at the Atlanta VA. And it is my pleasure to introduce Dr. Mallin, who's been waiting for me patiently. I'm sorry. She's joining us from the University of Arizona College of Medicine in Phoenix. She serves there as the Vice Chair of Education for their Department of Medicine and APD for their internal medicine residency program. She's heavily involved in the Academic Hospitals Academy, served as the chair of the GME Patient Safety and Quality Improvement Committee, among many other roles that helped shape her into the great educator and leader that she is today, and great coach, which is what she's going to be talking about today. So thank you so much for joining us, Dr. Mallin, and thank you for your patience.
No worries. Thank you so much for having me. Thanks to Dr. Kim and Dr. Hunt and the entire team of Educational Council and all of you all for having me here today. It is such a thrill. I'm really grateful to be here today presenting to you. Let's see if we can. All right. So this is where Arizona is. And I have to say that over the years, I've had quite a number of professional and now personal connections with many of you here. And I am excited to introduce to you one new thing that we have in common. We all get bragging rights because Atlanta and Tempe, Arizona are the two most livable cities in the United States as of like last week. So you know, we should do some sort of like sister city thing and really be able to really facilitate some of this. So it is really a joy to be here. So thanks again. I have no financial disclosures, but what important disclosure you should know is that I am not a certified coach. And I am proud to say that because it goes to show that coaching is not something that you have to be certified to be a certified coach, but coaching skills are things that we can incorporate into some of our daily lives. And so we're going to talk today about some ways to do that. Here are my learning objectives today. I hope to be able to share with you some of the unique value that coaching brings into the already very rich environment of medical education. I really hope to share a little bit about what's been going on in the many organizations that help feed medical education, who also very much value coaching. And most importantly, I hope that you all can commit to taking away one or two small little pieces that you get from this talk today. And I'd love to learn more that you are already doing to be able to take with you, even as you go about your day for the rest of today. So I have loved being here for many reasons, and one of which has been literally watching leaves falling off trees is like a really magical thing for me. We do not see a lot of this where I live. And so this has been a really beautiful moment of reflection. This is a time of year, changing of seasons, a time of reflection. There have been many, many things even in the last month that we've reflected about. So just to share a couple, there have been 10 days of reflection in the Jewish religion, where my family and I have kind of thought about that between Rosh Hashanah and Yom Kippur. National Coming Out Day was very recent, which is important in my family. Hispanic Heritage Month. There have been Indigenous Peoples Day, a way that we're reframing all of our history in new ways, just thinking about things, reflecting on things in a new light, have been really important in my own personal life and across society. So I encourage you to take just a moment. There's many people eating in the room, which is wonderful. But think for a moment as you reflect, looking at this picture, maybe a feeling, an emotion, a memory, something that this photo brings to you in your own reflection. I encourage you to jot it down if you can, or try to stay with it, because we might get back to this at the end of today's talk. We're next going to move to, come on, come on in. Plenty of room. We're next going to move to our learning and working environment, which is where we are here. I've now seen several different campuses, and I'm thrilled to see the wonderful learning and working environments that are part of your world. This is the old days, right? So this was taken from a fictional television show, but thinking about how, what the style of training was back in the day. See one, do one, teach one. The apprenticeship model, a very linear approach to who was the learner, who was the teacher, what you needed to learn to get to your next step. And I laugh when I look at this picture, because there's only one patient in the entire ward that you got to learn on, right? So very unlike the environment of today, which conceptually looks a lot more like this, actually. So this is work that was done by Rebecca Jaffe and one of my mentees, Christina Bergen, I'm proud to say, who did this work on building a conceptual model of what our learning and working environments look like now. They're complex. They are very busy. They're beautiful in color and very complex and rich in scope, where the patient remains at the center of what we do, which is very important, but it is surrounded and nested in these different domains. The personal domain, what's going on in all of our own individual lives, right, as learners. The relational domain, in which we are relating in teams that are more and more complex and bigger and multidisciplinary and all of those things, where we live in the curricular domain of our learning and working environment, and you are all steeped in that. You're here at Grand Rounds, that's part of your curricular domain. And then the structural domain that has to do with how we teach, how we create structures in place. The transition to EPIC as one example of some of the structural stressors and complexities that are part of your learning and working environment. And all of this is on very carefully on this little base of the sociocultural context, which in and of itself has become much, much more complex. And the truth is that this is getting to be quite a lot. The metaphor of the frog slowly boiling in water kind of comes to mind. Your learning and working environment might look pretty in a conceptual model, but when you're living in it and steeped in it, it can really feel like this. And it's really creating a lot of distress. It can lead to burnout. We've seen physicians who leave the specialty or leave patient care. We've seen too many physicians lost to suicide. It is an emergency. This is boiling water that we're living in, and we need to figure out lots and lots of ways to help get ourselves out of these situations. The good news is that you have lots of people around you who have been able to help with some of this. So the mentors, advisors, sponsors, other wonderful guides in our lives have helped us grow and get to where we are and help keep us moving forward. These are some of my own in my own life. Those are my parents who have played a very important role in my own guidance and through my life. In addition to the rest of my family. And these others have really helped me along my path in medicine and my own careers. The neurologist who exposed me to bedside rounding and made me fall in love with medicine as a field, as a career choice. The researcher in New York who taught me how to ask really great questions and help find those answers. People locally in my own institution who have helped guide me and expose me to all sorts of great new things. These are people, and I'm going to name one of them, Cheryl O'Malley, who some of you know. She started as a boss, mentor, sponsor, is now a very close friend and colleague. And this is how these relationships can sometimes evolve. And all of these people in your lives, I'm sure you're thinking of some of them right now. Think of how they've paved the way, really enlightened a viewpoint, sometimes shared some hard truths with you that were maybe hard to hear, sometimes protected you from hard truths that you don't even know about, but in other ways have really influenced and created space for you to grow and learn. And so I give a lot of credence to this group of individuals. And I also want to introduce you to a new option. And this is an option around coaching. It may be new for some of you, may not be new. But coaching is relatively new in medical education. And so we're going to talk today about the value of adding coaches to those other wonderful groups of individuals as another tool in the toolkit for us to help get through what is a very complex environment and help continue us toward the path of getting toward our personal best. Coaching as a philosophy is dedicated to supporting learners' professional development and growth and supporting them to reach their potential. A beautiful definition. I like the second one as well. Coaching is a process that guides a learner toward professional improvement. And what I love about the second one is that it speaks to my quality improvement heart. This is all around performance improvement. And this really maintains the learner as the center of the focus, right? So the learner is the expert, and we're going to talk a little bit about that. This is a way of thinking about what is the difference. Many people ask a lot of the time, what is the difference between a coach and a mentor, that kind of thing. One way to think about it is, who is the expert in this situation? When you go, I'm speaking to a room full of phenomenal residents. When you go and ask somebody for advice, you are asking them for advice oftentimes because you want somebody to give you the answer to something. Those are people who are experts, right? Mentors, advisors. I would like to invite you to think about the fact that you all often have exactly what you need. You are the experts in a lot of those areas. I, as a coachee, am the expert in what I need to do. And a coach enables me to somehow unlock some of that, what is not yet known to me, in order to be able to get me toward my personal best. And that is how they can function. Another way to think about coaches related to advising and mentoring is through the use of this kind of cartoon pictograph here. This is from the Academic Medicine last pages. I strongly encourage, if you read nothing else in that journal, the last pages are great nuggets of information. So this is a really good one. This shows the coach on the left compared to the advisor and mentor on the right. And you can see the circles behind them. The blue is how much time those individuals spend telling or answering questions, talking, basically. And you can see that the mentor and the advisor, that their job is to speak, is to teach, is to talk and tell you what their knowledge base is, what you can expect. What you can expect from a coach is somebody who will spend much more of the time probing, asking powerful questions, and really then listening, so that we can invite the coachee, the learner, to really build up their own steps toward professional growth. Many of you have seen what is become kind of the goal of academic medicine and medical education, is really creating master adaptive learners. This is a person who has a framework of learning and growing that is very similar to QI principles. Some of you might recognize the plan, do, study, act, these small tests of change that we do when we're doing a QI project. You can see this here as we learn something new and then apply it to new situations. There's a planning phase, a learning phase, an assessing phase, and an adjusting phase. And in each of these things, it requires some reflection, some critical thinking, plenty of growth mindset for sure, and the ability to be open to new ideas that helps us go from just absorbers of knowledge to adapters of information to be able to transform into new ideas, applying into new ways. We have no idea what the future holds in medical education and in healthcare in general. And so being these master adaptive learners is really going to help us get there. This was really conceptualized. There were several individuals that were involved in this, but the AMA Changing MedEd work has really utilized this and gone forward with it as it has developed a lot of the coaching curriculum around that. And coaching first became popularized, I think, in the lay press by Atul Gawande himself, who wrote this article for the New Yorker back in 2011. It's a great read. In it, he interviews musicians and athletes. These are people who are like primed for coaching, right? These are people who are really good at what they do already, and then they get coaching in order to be able to get toward their personal best. He invites a coach into his operating room who is not a better surgeon per se, but somebody who is able just to give him, to serve as a mirror to give him some feedback. And he purports to have gotten closer to his personal best as a result. And he writes, the concept of a coach is slippery. Coaches are not teachers, but they teach. They are not your boss, but they can be bossy. They don't even have to be very good at whatever it is. Mainly they observe, they judge, and they guide. Powerful words. What I love about this article the most is the simple notion where coaches make the unconscious conscious. Again, those are where the learner is the center, the expert at what they need to know. And a coach just simply is able to expose that for the learner to then take the steps needed to get to where they want to be. This is the TED Talk. It has a QR code attached to it. If you'd like to access that, I strongly encourage you to do it. So the Coalition for Physician Accountability is every acronym in medical education you ever heard of that got together to look at some of the challenges that are related to the transition from medical student to resident, from UME to GME. They created a council, the UME GME Review Committee, where they talked about what recommendations can we make in order to help improve that transition. You all have been through that transition. I don't think are there medical students in here? Oh, yay, welcome. You are the beneficiaries of some of the work around transitioning from student to resident, and then actually within GME programs from resident to fellow. So this will be beneficial to all of you as we think about what we need to continue to develop students and to create readiness for residency. Again, creating master adaptive learners. There were 34 recommendations, so I will not go into those, but I will tell you that 2 of them literally name coaching as part of their recommendation, that the use of targeted coaching by qualified educators is going to be very important for that transition to be as effective as it can possibly be. It includes coaching around the longitudinal work, and then also that in self-assessment and guided reflection. The ACGME is one of those organizations that got on board, and we now see for the medical educators in the room that deal with milestones. Milestones 2.0 includes coaching embedded in all of that work, and so in the core competencies of professionalism and patient care, there's several of them. Where level 5, the highest level of an assessment, is where a resident is able to coach others in that skill, and that is a sign of real success. There's also a requirement from the ACGME now for individualized learning plans that are being implemented. And this, I hope, sounds somewhat familiar, that there is a reflection aspect to it, self-assessment, goal setting, action planning. All of those things were those things that help us get to our personal best. And all of those things can be benefited by coaching. I'm going to share some of that work with you. The AMA, again, is another organization that a couple of initiatives that have happened from that organization include accelerating change in med ed, reimagining residency. They've sponsored numerous grants, many of which fund coaching programs in order to help us get that right, understanding how to most effectively create programs that effectively coach others into success. And they've developed quite a lot of coaching resources. There are online modules. I have yet another QR code for you later in the talk to access some of those online videos that are actually quite short and very impactful. In addition to handbooks, there's a textbook out now. Lots of ways to learn some of these skills, because coaching is hard. Coaching is actually, as a profession, coaching requires all sorts of certifications and exams, and there's levels of coaching that are implemented. For coaching in medicine, it was determined that we also need some competencies around this. So how can we create a whole cadre of coaches without having some structure? And so these 5 bullets on the right help us see some of the ways in which they've created some structure around that. So competencies now exist in these 5 domains, and you can imagine how great it would be to invite coaches into our prioritizing and goal setting aspects of that planning phase. To imagine how a coach might help a learner understand what learning strategies might work best in this situation, or how to critically appraise learning material. You can imagine how a coach might help one with a self-assessment is important. Guided self-assessment is even better because it often brings in some external feedback that's really important. And then adjusting to new ideas, new applications, new environments. Those are all things that are going to help create great learning. And those are things that coaches can help with. So we're going to take a little bit of a pause here. Again, my goal is to teach you a couple of micro skills that you can use. So these are prompts that you might be able to use. Think about a skill. I'm talking to the residents in the room, but I'm really talking to everybody. Think about a skill that you would like to improve upon. You might go to somebody who's more senior to you to say, gosh, I'm really trying to build my skills in having difficult conversations with patients. And I wonder if you could help coach me. That would be a wonderful signal to a more senior person to say, I'm looking for feedback specifically on this thing. I don't need feedback on something I don't want feedback on. I want feedback on this. So this is a coachee directed, right? You can imagine a peer coach, say one of the faculty in the audience. I think you are, really good at coaching residents, for example. I'm working on this myself. Can I get some advice, some coaching from you? A junior coach is also a really important teacher, right? A coach who is more junior to us might show us some things that we were previously blind to. So, hey, I'd really appreciate your feedback on the way I ran that meeting, that residency meeting. Even if you think it was good already, I really respect your opinion and want to hear your perspective on it. And that's a great way to invite somebody to really give you some honest feedback in order to effectively work toward becoming personal best. Everybody have something in mind, a skill in mind, and a person they want to reach out to. One of your action items for today, hopefully. So I'm going to talk for a couple minutes about the literature that supports coaching, because this is not a slam dunk, and you will see, I am not here to say that coaching is, the only way that we are going to continue to improve medical education. It is a tool. It is a group of tools actually that can help support our learners as they navigate through. This literature review was done in 2018, so that's already long enough ago that we have some new evidence. But at the time, there were 21 studies that were included in this review that had outcomes that were related to coaching programs. And as you can imagine, technical skills, like Gawande said, has a lot more robust evidence than other aspects of medical education. But I would say that coaching is shown to be very valuable in things around well-being and resilience, decision-making, teamwork, reflective practice. Gosh, that's the stuff of like resilience and building up, that mastery, that adaptive learning areas. And a couple of other important coaching interventions happened that improve patient safety outcomes. And so those are some of the things that absolutely make this, even, when it comes down to patient care, when we can directly tie a coaching program to patient outcomes, that's kind of pretty impactful stuff. So in 2019, AMA got a group of institutions together who were interested in coaching. And afterwards, they sent out a survey to understand a little bit more descriptively about what some of these programs do. 97% of those institutions either had or were planning to incorporate a coaching program. So that's not bad for 2019, given that a lot of this stuff has happened since then. And in that, all of the programs described having numerous goals. So it was not just one goal for their coaching program. There were lots of different domains, and these were some of them that they assessed. They also looked at the roles of the coaches themselves, because this is a really important area here, not to let fall by the wayside. A majority of the programs had coaches with protected time. Even if it was 5%, it was an important component of really bringing in some of that buy-in. The vast majority had some degree of formal training for their coaches. So even if it was a small, short time spent in formal training, it was still something that helped teach coaching skills to potential coaches. Most of the programs at the time did not they did not have coaches who assessed or formally supervised their coachees in the time. So this speaks to some of the kind of trust issues that we'll get into in a little bit. And then the majority had some sort of assessment of the coaches themselves or of the program as an evaluation. And so really important to measure how we're doing, again, with that whole goal of iterative practice and improvement. I want to share with you one of the tools. There are lots and lots of coaching tools. I'm not sure which ones have been in use here at Emory, but I do know that this is one that has been used across different kinds of learners and different kinds of settings for longitudinal feedback and coaching. And in this one, this is called the R2C2. It was then adapted to be used on the fly. And this coaching tool helps by building relationships, exploring the reactions and reflections of the learners as they're doing them, confirming content at the end of the feedback, and then coaching for change. And so you can kind of see the steps here. Building relationships is the important foundation of trust and psychological safety in any sort of environment where we are learning and training together. So what have you been working on? What are some of your goals? This keeps the learner at the center, right? They're the experts. And then another thing is, you know, we go on wards together starting tomorrow or today, and we are able to say, like, we're only going to have a week together. What are some of the things you want to work on? I know we haven't worked together before. Here's some things that you can expect from me. I really appreciate a feedback rich setting. So you should be expecting lots and lots of feedback, both big and small, in and out all the time. And I really hope that you'll do the same for me. And it's a way to build quickly a rapport with our learners. Then you might want to say about the event. So, you know, I am grateful that you let me into your delivering bad news conversation with the patient. How do you think that patient experienced? How was it for you? How was it for the patient? That helps the learner really like self-assess, lock in their knowledge. And then you might add a couple of things as a coach. You might be able to say, and everybody in the room can do this to somebody else, for somebody else in their team. Here's what I noticed in that conversation. What do you think about that? And it might be, I noticed that you just helped. Did you see the sense of relief that the patient had after you said what they said? Or did you see how the patient screamed and yelled at you when you said they're, something terrible? So like, those are some ways that you can really bring in some of that feedback and then confirm their awareness, confirm what you said this is teach back, right? This is tell me, let's make sure that what I wanted to say to you really landed. Help me understand that. And then coaching for change. What should happen next? Your goal to me at the beginning of this week was that you really wanted to improve your skills in having difficult conversations with patients. That is a phenomenal goal. And I watched a couple of these times. What do you want to do next based on everything that that has happened this week with our patients? What's your next step? What's one step that you're going to take as a result? Coaching for well-being and distress is something that has a lot of good support behind. So this is the dream team of Derby and Shanafelt. This is a pilot randomized controlled trial that was done in JAMA internal medicine a couple of years ago. And they showed an improvement over 5 months of professional coaches over the phone with their faculty at Mayo Clinic across all the institutions, including there's one in Scottsdale, actually. They looked at emotional exhaustion, other dimensions of burnout, quality of life, resilience. All of those things showed real statistically significant improvement in after this coaching program. What didn't change, interestingly, is job satisfaction, engagement, meaning at work. Those are so hard, right? These are the things. This is why there's so much work to be done. The complexities around work and work life are really, really hard. We joked yesterday, it used to be all about individual resilience, but Derby and Shanafelt taught us this years ago that it is not enough for our own individual improvement. We need to have some of these other system structures in place, these organizational, turning on Epic without any training is not a good idea. I hope they didn't do that to you. That makes it hard. How's anybody going to be excited about their job when they know that that's coming? There are some important things that have to change, and I get it. But thinking about what the organization can do at the unit level, at the program level, at the division level, at the department level, and beyond, all of those things are super complex. So coaching is not going to fix all that ails us, but it can help with our ability to kind of cope with some of that stuff, and then be able to really like engage in our own personal well-being and best. Okay. And here are a couple of examples of actually how the systems were improved as a result. So lots of institutions, including my own, actually have created longitudinal coaching programs for faculty. At the Cleveland Clinic, they did it, and this actually got a lot of press when this happened, because they incorporated a longitudinal coaching program that showed improvement in burnout and career satisfaction. They asked a specific question on their survey of how much did the coaching program impact your ability to stay at Cleveland Clinic? And a large proportion of the individuals said that it significantly impacted their ability. Cleveland Clinic enumerated that and created a $133 million price tag to that statement. So they ended up publishing this in a couple of different places, and it was really all over the lay press at the time. And this was in 2020, when people were not exactly, thrilled with their jobs. It was a tough time. Here's another one. This actually comes from Reed Pierce and his team on the National Task Force for Humanity in Healthcare. This was a multi-level intervention. So again, it wasn't just coaching, but coaching did play a big role in it at the individual and unit levels, to be able to see how people using positive psychology and coaching skills were able to really, again, appreciate and improve upon levels of burnout and workplace distress. And that pilot program was wildly successful. They were very, very pleased with it. And they're looking now, it actually kind of got a little bit derailed from the pandemic, and they're looking to build back some of that stuff. So really, it's promising. And again, it is not a be all end all, but it is certainly helpful. Yeah.
I'm curious, in these studies, are these physician coaches coaching faculty, or like, I'm assuming the licensed coaches they've got in terms of training, do they learn how to specifically work with physicians, and if that's sort of just recommended for us to seek out if we want to do coaching? Oh,
great. So there was a question in our audience here around are the coaches only physician coaches, or are they professional coaches? It's a mixture. I'm giving you a mixture. The one from Mayo Clinic utilized professional coaches by phone for a longitudinal one. The one I'm about to talk to you about is one that actually Emory was involved with. So there could be people in our audience today who participated in this program. This was faculty coaches in a coaching program of interns done several years ago. So you can shout out if you participated, but this was a very important study that didn't have all that positive of results. And so I want to just couch this tip by saying that I'm so grateful for this kind of study, because this actually, the lessons learned from this study are possibly the most important lessons around how to do coaching well. And so if it's okay, we'll get into that. To share that, so this studied ultimately 129 interns who did a pre and post survey across 5 institutions. And it looked at, this was another longitudinal coaching program done by faculty coaches who were recruited and trained to participate. And they looked here at the scale for well-being, which is called PERMA. You'll see that on the left. What I want you to know about these graphs here is that the x-axis is is baseline, and then blue is the desired direction, okay, for each of the different measures. And so you'll note that for the sense of well-being, this PERMA scale, men did much better than women. Women actually dropped in their scores over the course of that year. Another notable one was this change in emotional exhaustion, one of our dimensions of burnout that we use in the burnout inventory that you might use here as part of your programs. And you'll note here that residents who were white did fairly well, while residents who were, or this is interns only, but interns who were underrepresented minority groups did actually worse in emotional exhaustion scales. I'm like, what could this possibly mean, right? How could that be? And I think that the author suggests that we underestimate the complexities around life, work, residency so often, and that we as coaches, even who have been part of this world, just not some of us not very long ago, do sometimes either underestimate or overlook some of the other complexities. And coaching has an opportunity to really engage in some of that more actively, some of those contextual features that surround the challenges. These coaches were not trained to kind of address any of that, to my knowledge, but it really supports a more tailored approach to how we coach residents. And so I really appreciated that. And it really led me to think a little bit more deeply about coaching across differences. And so what I want to share here is a quick study that was done, a facilitated focus group study that looked at students who were underrepresented in medicine versus not. There were only 10 students in these facilitated focus groups, second and third year medical students. And the UIM students really noted a strong desire for coaches to have that emotional and environmental awareness of what they were going through and really give voice to it, and not just kind of maybe know it in the back of their heads, but really speak out loud some of that. This was not described as a need by non-UIM students. Underrepresented students also described in this study that it was really stressful and challenging to talk about sharing their vulnerabilities. And you can imagine, if you don't feel like you have trust in a system, it can become quite difficult to share vulnerabilities with anybody. And a coaching relationship is founded on a sense of trust and psychological safety. And so if you don't feel that, and you find it difficult to share vulnerabilities anyway, you can imagine how coaching might actually be maybe damaging, maybe actually increase our emotional exhaustion at the end of a year. This was the vulnerability sharing by non-UIM students was actually felt to be quite beneficial. And so it's just really interesting to think about how basically individualizing our coaching ideas and applications are really going to be very necessary. The other thing I just want to share here is that the matching of coaches to coachees, sometimes there is this stress, I'll just share with you at the program level, this tension of, should we be matching in some sort of dimension of identity so that people feel like they have somebody that they can be coached by who looks like them or comes from a similar background or something like that. And these students in this focus group really noted that concordance is not the key. And this is found in actually mentoring studies as well. It's not about matching dimension for dimension of identity. It's really around how we talk about it, not ignoring it, not putting it under, like sweeping it away. It's really about how that's part of who we are. And I think that that's a really important piece of it. So be aware, this is our opportunity for curiosity here, thinking about how there are individuals who might be uncomfortable with this dyad coaching relationship. And we need to learn more about that and get curious and ask those questions. There might be some mistrust in the system, even to the level of, is this conversation going to be recorded, or is this going to be on an assessment at some point? Those are important things that we need to be very transparent about up front. Just as healthcare inequities exist with our patients that we need to be aware of, educational inequity exists with many of our learners. And so really having an awareness of that and understanding and addressing those things will help us all promote thriving for our learners. We all need to be checking our own assumptions and biases that might impact these relationships and many others. And then I would just like to note that sometimes the dimensions of our identities, culturally or otherwise, exist, and so do individual identities. So personality types, communication styles, all of those things also play a role here and need to kind of come to the surface so that people can really get a sense of community and trust. I will end this slide just by sharing again that our identities across all dimensions are our strengths, and coaching is a strengths-based approach to wellness and mastering our professions. And so using those strengths, giving voice to them, embracing them, not ignoring them is probably the best approach. And then thinking about how just within diversity comes unity, right? So as we all learn about each other, stick with that curiosity, ask those questions with appreciative inquiry, and that really goes a long way. So this is Nike, the store, that tells you that there is a coach in all of us, and it's true. You do not have to be a certified coach, a professional coach, in order to incorporate some of the principles and approaches that we see here. We talked about that foundation of psychological safety and trust, and I'm going to share with you just 3 tiny but critically important coaching skills that really help in your next coaching session, however small that might look. Active listening is very important. Put away the distractions in the moment and really be present, be mindful in the moment as you're having a conversation with a coach or coachee. Acknowledging the other person, recognizing their strengths, recognizing that they are the expert of their own lives is a really important thing to give voice to. And then asking powerful questions. That is what coaching is all about. And here's an example of just some of my favorites. These powerful questions are ways that we unlock learning in our students and residents. These are open-ended questions grounded in this trusted relationship. And we again assume that the coach has all the expertise that they need. One of my favorite coaches taught me that when I say, like, how do you always know, like, just the right question to ask? Well, that's part of training and coaching. But also she's like, it's actually, I'm just like your inner 5-year-old child. If anybody has a 5-year-old, you might I have to think back a little longer for that, but the 5-year-olds are the geniuses, right? We think they are so smart because they get to the heart of just what it is that makes you think and go, how do I get from this to that? How do I figure out the next steps here? So these are some really good ones. And this is just one small thing that you can do. Instead of saying, like, why did this happen the way it did? Why did this patient, get all upset with you? Tell me why? That's not for the coach to know. The coach doesn't need the expertise. The coachee has the expertise. What did you notice? What was present? What was the situation that you were in that led to this behavior? What do you want? What's a goal? What's a goal of yours? What does success look like, feel like? What might be working for you in this area? What isn't? How might we reframe what we're talking about here and think about this from a different perspective? Sometimes that just like unlocks, oh my goodness, that was one that really helped in my own personal life. What are some of the things in your control? Next steps. What else? This is one I use with teenagers. This is a good one for teenagers. This is the one where the patient, like your hand's on the doorknob and they're like, oh wait, doc, I have one last thing for you. This helps prevent that, right? This is the what else is important for me to know? What else do you want to share? And then you wait, and then it comes, and there's always something else. And when a teenager gives you a new thing to talk about after your what else question, you're like, oh my gosh, yay, they're communicating. It's awesome. And then finally, coaches love supporting, right? That's what our jobs are as coaches, all of us collectively now. How else can I support you in your plan? What else do you need from me? All right, so this is that coach that is the inner 5-year-old. These are the 5 mistakes and the hundreds of times that I've made them personally, but things to remember and how to avoid them. We are a profession of fixers. We are a profession of advice givers. This is what we do for our living. But coaching gives us a new way of talking and thinking about things so that we should take those things off the table. When our coaching hats are on, the doctoring hats, the diagnostician hat, the advice giving hat, all of those things have to not be on your heads so that it's truly coaching experience. Finally, we talked about asking, how can I be most helpful? And then finishing without a commitment is the other thing. Thinking about how coachees grow when they have new insights and they take something with them. They take an action with them. And so this is what we as coaches can help hold accountable, is what new action is going to be shared. Now, I reflected on your beautiful fall leaves. You get to now reflect on my beautiful desert. This is the Botanical Gardens in Phoenix. You are all welcome to join me anytime. As you look at this gorgeous photo, I'll share with you a little bit about my own coaching experience. I first learned about coaching as it relates to medicine because I am definitely not an athlete and I'm sadly not really a musician either. And so never really received coaching in those very effective ways. But we were interested. There was a group of us that participated in a faculty learning community and got really interested in learning about it. A little bit later in my career, as I was developing some leadership training, I had the opportunity to explore some executive coaching. And that really changed my thinking around coaching as I saw how impactful it was for me. And most recently, we've been able to create a couple of coaching programs that I'm going to share with you now. So this was one of the Building Trust grants by this group of organizations where we did kind of a triple threat here. So residents were telling us that there was mistreatment happening by patients and that it seemed to be getting worse. And they didn't know why it was getting worse, but it was getting harder and harder to handle. And we were quite surprised. There have always been kind of some of those flights in medicine that we all can kind of appreciate, but it seemed to be getting worse. And so we decided to use that as an opportunity to develop a coaching program where residents were coached through navigating mistreatment by patients called RISE. We then developed a coaching skills development course for faculty. And then we paired the faculty with small group coaching sessions with those residents between their workshop sessions, if that makes sense. I am sad to report that it is too soon to share results with you, but they are very encouraging. All of our PGY 2s and 3s participated in this. It was we embedded it in a curriculum that they all were doing anyway. So it was really nice and elegant that way. We unfortunately saw that verbal mistreatment was common, and this was kind of a reaffirmation of our ACGME results. And as far as the results to date, we have seen significant improvement in residents reporting that they are much more confident than they were at the beginning on navigating some of these episodes of mistreatment. And so that was wonderful news to us. We do not yet have data on the coaching aspect of the program, but anecdotally here, some positive results. Here's our second coaching program that we've initiated. We kind of started them similarly at the same time. And the PI on this one is Cheryl O'Malley again. And this is a grant from the AMA looking at a coaching program and exploring emotional intelligence. So this program is a 2-year-long faculty coaching development course and a 1-year-long, so 2 cohorts now of residents and fellows across all GME programs. So the first one was around internal medicine residents. The second one is self-selected GME house staff, basically, and faculty from all the GME programs. This one, we have some results that I can share. So I'm happy to report that emotional intelligence scores were statistically significant in both groups. This is the kind of quantitative part of our study. And well-being index for the total, each group was too small to really gain some statistical significance. But by the time we got to the total, our well-being index actually also showed benefit. So that was helpful. This is all, again, in that first year of the core of the program. And in our qualitative interviews, just to kind of, I'll go quickly here, the qualitative interviews did show, and this is mostly from faculty, showed that these coaching skills are not just being applied to their coachees, to their residents and fellows and other learners, but they're actually using them in their personal lives. So people are loving kind of unlocking knowledge in their children and their spouses. It's really been helpful in other social situations as well. And then just the self-awareness. So this is just proof that the emotional intelligence piece has worked, because the self-awareness, which is one of the pillars of emotional intelligence, that I'm reading here in some of these comments has been really I kind of chuckle that like this is showing me that they certainly are developing some self-awareness in some of their comments. So in our coaching programs, what I can share is that we have learned lots of lessons. We have really benefited, back to your original question, is that professional coaches for us gave us a lot of benefit. They're not cheap. And so that is definitely a barrier for some programs, but we were grateful and very fortunate to have that additional level of expertise that I think really helped. We started with very self-selected, highly motivated learners, both because people wanted to not be mistreated or not feel distress because of mistreatment, but also in the other GME-wide program, they were self-selected, so they chose to participate. It really helped us to create time and space embedded in a curriculum. While I'm sure lots of you would love to come back to the hospital late at night after you're done seeing your patients all day and spend more time together, not everybody wants to do that. And so that can be quite a barrier. And then accounting for the time it takes, the logistics are not small. So paying attention to that up front. And then I am again so excited that I get to work and live in this kind of innovation incubator that is my institution. And so we play a lot with new ideas, new innovations. We try stuff, we see how it goes. We do rapid cycles of change on most medical education interventions that we try. And so we're glad to be in able to kind of experiment in that way. So rather than being in boiling water, let's create these bubbles of positivity in our learning environments, right? So where feedback is normalized, where goals are clear and stated and expected and encouraged, where we have these trusting relationships between all of us, where the alignment is really in place so that we can really all collectively kind of attain or get closer to our personal best. And I guess I'll just think about, if you are willing, I know we only have a couple minutes left, but if anybody has any those early, remember the fall leaves, thinking about that slide and that reflection and the moment of joy or emotion or memory that you had while thinking about that, now is your time for action. So commit to something. Send a note of gratitude to somebody that you were just reminded of. Go commit to taking a walk to enjoy the fall leaves, although it is so cold out today. Too cold for my Arizona blood. Spend some time not just reflecting, but then in taking some action. And then you all get a little bit closer to your own personal best. For future directions, again, this is not a panacea. This is one of many interventions that will be necessary to improve medical education in the future. There is a clear benefit to coaching in many different areas, but there's a lot of unknowns out there. And so I get really excited about this part, being able to figure out some new ideas and ways to kind of bring up some new energy. If anybody ever wants to partner on any of this, please let me know. These are some additional resources that I promised you. To the right are just some books that I've kind of alluded to throughout this talk. And on the left are some of those AMA resources, including the QR code to the videos. And I will end here. Thank you all so much.
Thank you so much, Dr. Mallin. That was a great talk. I just want to remind people to feel free to ask questions in the chat. And I guess I'm going to start with a comment first. Dr. Lynn O'Neill says, when discussing identity concordance with a colleague regarding a mentor-mentee pairing, on the sage advice from my colleague was that race concordance is less important and soul concordance is what's important. And then Dr. Higgins, Stacy Higgins, who mentioned earlier too that our Emory interns participated back in 2019 and 2020. Asks, so basically there's a lot of data supporting the benefits of coaching for the coachee. What are your thoughts on how coaching impacts the coach, specifically as we think about areas of burnout in our coaching program? Many of the faculty anecdotally reported that had positive impact on them as well.
Well, I planted Stacy in the audience. So thank you, Dr. Higgins, for that great question. I would say that faculty, in my personal experience and what I've read in the literature, is that it is the creation of a community of practice is really very palpable. Those are results, again, that I wasn't able to share with you with what we are finding with our own coaches, but coaches who participate collectively in groups like this, either through their training and then coaching others, really do kind of get a sense of well-being and their own sense of support and safety in that. And so thank you again for the question. I think it has benefits in all areas that we can kind of lean on.
Yeah, a lot of people saying thank you for the good talk. And I missed Dr. Manning mentioned being seen being important for that relationship, the coach-coachee relationship. Any other questions or anything? Okay, great. Thank you so much, Dr. Mallin.
Thank you. Thanks, everybody. Have a great day.